Welcome to this special series of Diabetes Core Update, where we will discuss chronic kidney disease, that is CKD, and type 1 diabetes, a need for therapies. I'm your host, Dr. Neil Skolnik, professor of family and community medicine at the Sidney Kimmel Medical College of Thomas Jefferson University, and this special series of Diabetes Core Update is sponsored by Bayer. Joining us to discuss this topic, we are privileged to have Dr. Janet McGill. Dr. McGill is a professor of medicine at the University of Washington in St. Louis. She's been an active clinical researcher in diabetes for over 25 years, continues to test new therapies for diabetes, as well as novel approaches to type 1 and 2 diabetes. Dr. McGill has served on the steering and safety committees for multi-centered clinical trials, including the RENAL study, TREAT, FOCAL, KEEP, SUN, and PEARL studies in diabetic nephropathy, and currently serves on planning committees and data safety monitoring boards for a number of national and international clinical trials. She's also an excellent teacher and is the former director of the Fellowship in Endocrinology, Diabetes, and Metabolism at WashU, and received the Outstanding Physician Clinician in Diabetes Award from the American Diabetes Association in 2022. Janet, welcome to the ADA's podcast.
Thanks, Neil. It's a great pleasure to participate in this podcast and to let people know about CKD in patients with type 1 diabetes.
It's such an important topic. And before we jump into the topic, can I ask you to share what got you interested in nephrology and diabetes?
I joined the faculty at Washington University about the time that the captopril in diabetic nephropathy study was getting started. It ran concurrently with the DCCT. So I worked with Julio Santiago in the DCCT, and I was the site PI for the captopril in diabetic nephropathy study at Washington University. Both of them were published in 1993, and both are considered landmark clinical trials.
Yeah, they sure are, and I can see how that's inspiring. You know, it's very interesting. We'll talk in a little bit about where RAS inhibitors fit in, but it's also interesting to think how long ago that was and how few therapies we've had since those initial RASI trials that have really addressed nephropathy in type 1 diabetes. Now let's jump into our discussion, and that really brings out the fundamental dilemma now in diabetes care and kidney care, and it's clear that the development of CKD is important. It has incredible potential adverse consequences in both type 1 and type 2 diabetes. And as alluded to over the last few years, we've seen really solid evidence supporting efficacy of a number of classes of medicines that decrease the rate of progression of CKD and decreased cardiovascular consequences of CKD in people with type 2 diabetes. We've discussed that actually a lot on our last two podcasts, but we don't have the same armamentarium available for people with type 1 diabetes. And today we're going to talk about what is available and the importance of continued development in this area. First, though, to level set, can you go over the prevalence of CKD and type 1 diabetes and why it's important to address CKD in people with type 1 diabetes?
Sure. The best study that addressed this is the CURE database out of the Providence system on the West Coast. They found that 27% of people with type 1 diabetes have chronic kidney disease. That's really high. It's a lot of people who are headed toward adverse outcomes. Increased burden of CKD was found in women, racial and ethnic minorities, older adults, and those with pre-existing cardiovascular disease. So we have a very large problem to deal with in people, in adults with type 1 diabetes.
And question, Janet, is there the same relationship in type 1 that we see in type 2 where CKD also increases cardiovascular adverse outcomes?
Absolutely. CKD is a harbinger for cardiovascular disease and for heart failure.
Right.
It's
that makes sense. Yeah.
very important to slow down progression of CKD to forestall these other serious illness burden problems.
Yeah. And can you touch on the pathophysiology of diabetic kidney disease in people with type 1?
So this is very complicated.
Please don't make it too complicated for us.
In type 1 diabetes, I think that there is a greater influence of prolonged hyperglycemia. It alters kidney cell energy metabolism, protein kinase C activation, advanced glycation end products, and mitochondrial function. In addition to the hyperglycemia burden and duration, we have then hemodynamic dysregulation that everyone is familiar with, RAS activation, hypertension, glomerular hyperfiltration, increased tubular sodium reabsorption, and these factors interact with each other to form ultimately a setting of inflammation and fibrosis. There are pro-inflammatory cytokines and all of the usual suspects that cause inflammation and fibrosis that limits filtration capability and also impacts tubular function.
And that's helpful. And thanks for keeping it under an hour and a half in terms of your discussion of the pathophysiology. But that gives us a sense of what's going on, and particularly as you mentioned, inflammation and fibrosis, that also relates to some of the therapies that we have available. And before we talk about those therapies, can you remind our listeners of recommendations for screening for CKD in people with type 1 diabetes? Because we can't help people if we don't know they have CKD.
Screening is critical. People with type 1 diabetes should have annual assessment of creatinine that should then allow a calculation of estimated GFR and urine albumin excretion that we now call UACR. At lower levels, testing for microalbumin by radioimmunoassay is appropriate because it picks up those low levels. Once the patient has overt albuminuria or proteinuria, then it's possible to do protein to creatinine excretion, or UPCR. That's done by a colorimetric method. Is an older method, but it's what captures the total burden of protein excretion.
And it's so important that our listeners remember to do that UACR, because my understanding is nationally we're still not quite where we should with urine albumin to creatinine screening routinely, and that routinely is annually along with the serum creatinine. Briefly, and to look at this in terms of contrast, we alluded to there's so much going on now for CKD and type 2 diabetes, not as much in type 1. Can you briefly go over what therapies are available for people with type 2 now to slow progression of chronic kidney disease?
Sure. So in type 2 diabetes, the approved therapies are the ARBs, consequences of the Ronell and IDNT trials. The next set of studies were the SGLT2 inhibitor studies that have a rather profound impact on reducing proteinuria and slowing progression. After the SGLT2 studies, or during that time, finerenone, which is a nonsteroidal mineralocorticoid receptor blocker, was tested in two studies, Figaro and Fidelio. They were very similar. One had a cardiovascular focus, the other had a chronic kidney disease focus. When they were combined into a meta-analysis called Fidelity, became clear that finerenone has a very significant impact on prevention of the combined endpoint of 57% reduction in estimated GFR, progression to end-stage kidney disease, and death. So finerenone is now the third pillar. Then finally, the FLOW study was published that showed that semaglutide also had a positive effect on reducing albuminuria, but more importantly, reducing progression, cardiovascular outcomes, and death. So we're waiting additional studies with the other GLP compounds. So we will see what they tell us. But the four pillars of therapy are now ACEs and ARBs, SGLT2 inhibitors, nonsteroidal mineralocorticoid receptor blockers, and GLP-1 agonists, and that may get expanded.
Yeah. So that's really helpful to have that as our base when we think about things. And before we go on to therapies for people with type 1 diabetes, can you also address the impact of glucose control on the progression of CKD in both type 1 and type 2?
Glucose control is critical. This was shown in the DCCT and most demonstrably in the 25-year follow-up of the DCCT edict cohort. In that follow-up study, comparing the original intensive therapy group with an A1C of 7-ish to the conventional therapy group with an A1C of 9-ish, a 50% reduction in microalbuminuria was found. Also, a 50% reduction of estimated GFR less than 60 was found in the intensively treated group. So when we carry that forward, the PEARL study was a negative study. But what came out of PEARL was a paper that showed that glucose control still matters for rate of progression of loss of kidney function in type 1 patients with chronic kidney disease.
It's pretty amazing. Am I right, the term legacy effect describing having good glucose control, in this case DCCT, 25 years before, still shows an effect 25 years later?
Yeah, that effect is called the legacy effect or glycemic memory, a couple of names for it. And there is a growing body of literature that shows that it has really rather profound effects on complications and even mortality. Some of this data comes from the UK PDS, which was the other large type 2 study. But certainly we see it in type 1 diabetes in the DCCT cohort.
Yeah, it always is amazing to me because complications always seem distant and it is hard to maintain one's enthusiasm, not even so much as a doctor, but to keep patients enthused about all the work it takes. And yet recognizing that what you do today, it's kind of like planting seeds in the early spring for the fall harvest. What you do today yields its harvest and benefit years later. Let's now move on to therapies available for people with type 1 diabetes.
The answer is the therapies are limited. The number of studies is very limited. After the captopril trial, there are a number of trials that were negative, and those are more or less forgotten. Iminoguanidine, tolrestat, some of these older therapies, the studies are negative, and so we don't really consider them. The recent study of allopurinol, aiming to lower uric acid, was completely negative. So we have glycemic control and ACEs or ARBs. This combination has really made a difference, however, and we can tell that by comparing the two groups of patients, one that entered the captopril trial. These patients had total protein excretion of 2,500 to 3,000 grams in 24 hours. The age of the patients was 34 years. The duration was 22 years. So in FINE-1, the age is now 51.5 years. So about 15, 16 more years of good kidney function. The UACR was 540 milligrams per gram, so much less albuminuria. The eGFR was lower at 57. What does that tell us? I think it tells us that by lowering UACR with glycemic control, with ACEs and ARBs, that we can prolong the life of kidney function in people with type 1 diabetes. However, at 51 years, patients now are showing evidence of chronic kidney disease, and this high UACR is a marker for progression.
Yeah, that makes sense. And so we've done a lot with glycemic control, with ACEs, with ARBs. What else is in our armamentarium in the 30 years from those trials till now?
Yeah. So the recent trial that was completed is the FINE-1 trial. FINE-1 tested finerenone versus placebo in adults with type 1 diabetes over the age of 18. UACR had to be 200 to 5,000, eGFR 25 to 90. So this is a very broad catchment. It was an international trial that randomized 242 patients, so relatively small trial. 120 were randomized to finerenone, 122 to placebo. As we mentioned, they were about 50 years old. Blood pressure was in the mid-130s, systolic. About 30% had cardiovascular disease, and the majority had hypertension. And over 95% were on ACEs and ARBs. So what did this study show? It was a 6-month trial. The endpoint was reduction in UACR. The study showed that finerenone compared to placebo reduced UACR by 25% over 6 months. This was a positive outcome and mirrored the effectiveness of finerenone in reducing albuminuria in the Fidelity cohort. So in that first 6 months, results of the FINE-1 study were very similar to results of the type 2 studies.
That's interesting, and it may be obvious, but I'll ask, can you describe the rationale for using UACR as a primary endpoint? We're used to endpoints that are different than that, triple endpoints, creatinine doubling, et cetera, in other studies. What was the rationale for UACR here?
The rationale was to use UACR reduction as a bridging biomarker. So bridging biomarkers is a concept that is typically used when you're testing therapies approved for adults and moving them into pediatrics. So you do a smaller study in pediatrics, maybe not as, maybe shorter, and the goal is to have the least amount of burden, but show similar efficacy and side effects. So this bridging biomarker concept works for finerenone because a striking percent of the effectiveness of finerenone in the composite kidney endpoint was related to UACR reduction. So if UACR reduction is a marker, then FDA signaled that it would consider using UACR reduction as a bridging biomarker for approval of finerenone in people with type 1 diabetes and chronic kidney disease. And I'll add one other thing. There needs to be pretty good evidence that the side effect profile will not be different. And we have no reason to assume that the side effect profile of finerenone will be different in adults with type 2 diabetes versus adults with type 1 diabetes. And that's what we found in finerenone.
So you found similar rates of hyperkalemia, I gather.
Yes.
So that's important. So what do you see as the implications of this for clinicians?
The implication of the FINE-1 trial, and with caveat that it has been submitted to FDA, but we have not heard about their approval at this point. So it's at FDA for approval for use of finerenone in patients with type 1 diabetes and chronic kidney disease evidenced by UACR greater than 200.
So that's exciting because, as we talked about in the beginning of the podcast, it has been a long time since we had a new therapy for people with type 1, and clearly new treatment for chronic kidney disease is critically important for people with type 1 diabetes. Before we finish up, are there any other medicines that are being looked at in the pipeline for efficacy in people with type 1 diabetes and chronic kidney disease?
Sure. The GLP-1 therapies are being tested again in people with type 1 diabetes. If they are shown to have some efficacy and safety based on maybe newer dosing considerations, for example, we may be able to use GLP-1 types of therapies in this population. I don't know of a kidney disease trial that's underway, but the indication will simply be type 1 diabetes, which will allow us to use it as we need to.
Yeah.
There is another study, the sugar and salt study, testing sotagliflozin in people very similar to the FINE-1 cohort with type 1 diabetes, chronic kidney disease with similar UACR. So that study is underway and will take a little while to read out. There is retrospective evidence from the SGLT2 inhibitor registration trials that it will have the same effect on UACR in type 1 diabetes as it does in type 2, though they were not designed as kidney trials. There are safety concerns, and these safety concerns are very, very real. In the sugar and salt study, everyone gets a ketone meter. Everyone's required to test ketones. People are testing ketones. And we find every so often a patient with higher ketone levels, higher beta-hydroxybutyrate levels. So we're anxious for the CKM continuous glucose and ketone monitor to see if maybe that will help mitigate the episodic ketosis that can occur in type 1 diabetes.
Boy, that's fascinating. We talked earlier this year with Guillermo and Perez about continuous ketone monitoring, and this sounds like it would be a critically important place where that would have a lot of utility. Janet, thanks for going over things in such depth and with such clarity. We're about out of time. Any final thoughts for our listeners?
The number one thought is please screen your patients. Please screen them. Please consider treating and following their kidney function, referring as necessary, and using therapies with proven effectiveness.
Dr. Janet McGill, thank you so much for joining us.
Thanks, Neil. It's been great.
And most of all, of course, thanks to our listeners. Thank you for joining us on this special edition of Diabetes Core Update discussing CKD and the importance of new therapies. We've heard a lot of new information. We've talked about the critical importance of screening for early detection. We've heard a wonderful perspective on the incredible impact of ACEs and ARBs and glycemic control over a very long span of time and the importance of addressing things now when we see it. And we have had a glimpse into the future, looking at the FIND-1 study of finerenone. Janet, I so appreciate sharing the concept of bridging biomarkers, which is a new concept for lots of people to understand the data behind finerenone and CKD that is currently at the FDA. This special edition of Diabetes Core Update is sponsored by Bayer. We thank you for listening. And for the American Diabetes Association, I'm Dr. Neil Skolnik. Till next time, stay safe and keep learning.